Hello, everybody. This is Jeanne E Poole, Editor-in-Chief of Heart Rhythm O2, and welcome to the March 2025 podcast. This is coming to you a little bit late, for which I apologize. We've been busy here at HRO2. Hopefully, you've had a chance to look at some of the great March papers. Also, I want to draw your attention to a special thanks that is one online page. It's thanks to all of our reviewers, so all of your names should be listed if you reviewed for us in 2024. I cannot tell you how much we appreciate it. We know it's a labor of love, but that is why we're able to produce great papers, and I hope you actually find it enjoyable. Thank you so very much. Okay, we have a lot of papers today, and as you probably know by now, sometimes I just simply read the key findings or the abstract, or sometimes they're a little bit longer if I think the methodology needs some more information from the main paper. So it just kind of varies depending upon the paper. So up first is a paper titled Current Clinical Practice versus Remote Monitoring Recommendations for Cardiovascular Implantable Electronic Devices, a real-world analysis from a remote monitoring database by Dr. Matteo Bertini and colleagues. The purpose of the author's study was to evaluate current clinical practice to inform adjustments to better follow recommendations and improve the use of remote monitoring, with a specific focus on the timing of enrollment related to CIED implantation and whether or not customized alert-based programming occurred. These authors used the Boston Scientific Latitude database, and they were able to identify 6,553 CIED patients, which represented 26 centers between 2010 and 2023. This included data on all types of CIEDs. The data were de-identified for any patient identifiers, and a comprehensive group of data factors were collected, including enrollment dates, frequency of scheduled transmission, program settings, and alerts. In terms of patient enrollment, this significantly increased over the observational period. 73% of the patients were enrolled within 2 weeks of implant and 94% within 3 months. They also noted that the use of remote monitoring in general increased over the study time period. The overall median remote monitoring duration was 40 months, during which 96% of the patients performed remote monitoring transmissions, which were scheduled every 3 months in 96% of the patients. 14% of the patients were noted to have interrupted connectivity without a difference across CIED types. They also looked at in-office remote transmissions. And between 2010 and 2023, 36,672 were performed. The balance of remote scheduled versus office-based transmission was 52% of the total. Patient-initiated was 28%, and alert-based accounted for the remaining 20%. An alert condition was present in 3% of scheduled transmissions, 2% of patient-initiated interrogations, and of course 100% of all the alert transmissions. In just 2023, there were 6,600 in-office interrogations performed and 70,453 remote transmissions were reviewed. And of course, keep in mind, this is just for one device company. The authors conclude that the use of remote monitoring in clinical practice is increasing with both more in-office and remote visits. The use of the alert-based strategy appeared to be low, which if used could decrease the number of both scheduled remote visits and in-clinic visits. The authors note that there's a need to improve adherence to guidelines and encourage more use of alert-based remote monitoring that is customized to the patient. Next up is a paper titled Adoption of Left Bundle Branch Area Pacing Using Stylet-Driven Leads in a Tertiary Academic Training Center, Learning Curve, and Acute Procedural Outcomes by Dr. Soraya Hani Kamsani and colleagues. This paper evaluates the learning curve for implantation and adoption of the Biotronic Soleus stylet-driven left bundle branch area lead in a tertiary academic training center between 2022 and 2023. This is a retrospective observational study. Factors included procedural and fluoroscopy times, ECG, and pacing parameters. 69 patients were included in the study, all of whom underwent a left bundle branch area lead implant for pacing indications, and 75% were male. There were 10 different implanters, which included 7 fellows over the observational period. The mean total procedural time was 74 minutes. Mean fluoroscopy time was 9 minutes. Mean pace QRS duration was 115 milliseconds. Mean left ventricular activation time was 79 milliseconds. An RSR prime pattern was achieved in 76.8%. Left bundle branch area pacing was considered successful in 78%. Overall, 43.5% achieved this with a single deployment, with a median for the entire group of 2 deployments. They noted excellent left bundle branch area pacing lead parameters with a threshold of 0.86, sensing 9.4, and impedance 627 ohms as an average of the whole group. Acute procedural complications included damaged lead helix requiring a second lead in 4.3%, pneumothorax in 2.9%, and acute left bundle branch area pacing lead dislodgement in 1.4%. Septal perforation occurred in 10.1% of the cases with no acute sequelae. When analyzed in tertiles, the number of lead deployment attempts was reduced over time, but with no changes to procedural success rates with increasing experience. This is shown in the author's figure 2. The authors conclude that adoption of left bundle branch area pacing with stylet-driven leads in an academic training center is feasible and safe, with satisfactory success rates and no overly steep learning curve. They offer the following key findings. First, real-world adoption of left bundle branch area pacing procedure in a low to medium volume tertiary center is feasible with acceptable success rates. With increasing operator experience, there was a reduction in the number of lead deployment attempts as well as a trend toward shorter procedural time. And third, overall, acute procedural complication rates were low. The next paper title is Pacemaker Implantation After Surgical Aortic Valve Replacement and Balloon Expandable Transcatheter Aortic Valve Implantation, Incidence, Predictors, and Prognosis by Dr. David Gapieri and colleagues. This paper focuses on an ongoing challenge, which is the continued occurrence of AV block following both surgical aortic valve replacement and TAVI, and the hunt to find robust predictors of needing a permanent pacemaker. This is further complicated by the observation that many patients recover conduction after discharge and over the first month. This is a single-center study from the Emilia-Romagna region in Italy. The authors look at predictors of needing a permanent pacemaker pre-op, analyzing their data from 2010 to 2020. Patients were identified using a regional electronic medical record. The Euroscore 1, Euroscore 2, and STS prob scores were identified for TAVI and SAVR. Outcome measures included length of stay, 30-day mortality, in-hospital mortality, rehospitalization, stroke, heart failure, all-cause mortality. In addition, angiographic and CT parameters included leaflet anatomy, LVOT measurements, device landing zone, and calcification of the leaflets and LVOT using prior standards for determining significance. The authors observed that over that time frame, 1,486 patients had surgical aortic valve replacement or TAVI using balloon expandable transcatheter heart valves. The mean Euro 1 score, Euroscore 2, and STS PROM scores were compared for TAVI and SAVR respectively, and these were 15.9% for TAVI versus 7% for surgical, 5.2% for TAVI versus 2% for surgical, and 4.5% versus 2% respectively. The mean age of TAVI and SAVR populations were 82 and 73 respectively, so a little bit older in the surgical population. Other comorbidities were also more frequent in the TAVI population. The surgical group was more likely to have a bicuspid aortic valve. In terms of the TAVI types, the SAPIEN 3 valve was implanted in about half of the cases, followed by the Edwards SAPIEN ET, SAPIEN Ultra, and the Edwards SAPIEN THV. 42% of the cases were achieved using a 26mm valve. All-cause survival for all patients was 98.9% at 1 year and 95% at 5 years, dropping down to 61% at 8 years. But it was much lower in the TAVI group compared to the SAVR group, dropping down at 5 and 8 years to 59 and 38% respectively. The authors found that in their population, the 30-day incidence of permanent pacemaker implantation in the TAVI group was 3.4%. Another 14 patients, or 4.8%, had a permanent pacemaker implanted greater than 30 days out. While a 30-day permanent pacemaker implant did not affect overall survival with a log-rank p-value of 0.494, in a multivariate analysis, PPI did predict rehospitalization due to cardiac causes, and it was associated with having calcifications in the aortic valve at the leaflet, LVOT calcification, device landing zone calcification. Also, a higher implantation site was protective. Right bundle branch block was predictive of needing a permanent pacemaker implantation. The authors conclude that a low 30-day permanent pacemaker implantation incidence rate was observed primarily because of the exclusive use of balloon expandable sapien transcatheter heart valves and high implantation techniques. Baseline factors such as leaflet, LVOT, and device landing zone calcifications, as well as right bundle branch block, were predictive of needing a permanent pacemaker. Permanent pacemaker implantation was associated with longer length of stay and rehospitalization for cardiac causes. The author's key findings are first, that balloon expandable sapien valves have resulted in a low 30-day permanent pacemaker implantation rate of 3.4%. In addition, performing a high implantation technique has been confirmed to reduce the risk of needing permanent pacemaker. Permanent pacemaker implantation has been strongly associated with rehospitalizations due to cardiac causes during follow-up. Its influence on overall survival has not been reported, and it might require further investigation. Preoperative CT scan factors such as leaflet LVOT and device landing zone calcifications using quantitative methods have emerged as being predictive for needing a permanent pacemaker implant. The name of the next paper is Prognostic Impact of Atrial Fibrillation in Patients Undergoing Transcatheter Aortic Valve Ablation by Dr. Jacob Reichel and colleagues. So here's another paper focusing on TAVI, but looking at the risk of atrial fibrillation. This is an analysis of a prospective registry that is a multicentric registry mandated by the Swiss government. The authors are from the University Hospital in Basel, Switzerland. In addition to common clinical variables, the presence of prior AF and discharge AF were collected. Patients had a 12-lead ECG the day prior and then daily until discharge. New AF was defined as AF lasting 30 seconds or more on any ECG recording type. NOACs were held 48 hours prior and restarted the morning after the procedure for patients with a prior AF history. Adverse events were all adjudicated by a clinical events committee. Primary outcome was all-cause mortality at 30 days. Secondary outcomes included all-cause mortality at 1 year, stroke at 30 days and 1 year, any procedural success defined as freedom from peri-procedural mortality, surgical reinterventions of the aortic valve, major access site complications, and peri-procedural bleeding until discharge. The authors identified 1,655 patients undergoing TAVI, of whom 428 patients, or 25.6%, had pre-existing AF, and 77 patients, 4.6%, were diagnosed with new-onset AF during hospitalization for TAVI. At discharge, 452 patients, or 89.5%, with AF received oral anticoagulation. An association of AF with higher 30-day mortality was observed, 3.7 versus 2%, with a p-value of 0.054, hazard ratio 1.8, but it was associated with higher 1-year mortality at a statistically significant level, 13.8% versus 8.4%, and adjusted hazard ratio is 1.6. After adjusting for potential confounders, however, there were no difference in mortality at 30 days. In terms of strokes, the stroke rate was higher in patients with AF at 30 days, 5.9 versus 2.7%, and at 1 year, 7.1 versus 3.8%. However, for those patients on NOACs, no difference was observed. Patients with AF had more major or life-threatening bleeding complications, 14.2 versus 10.6%. There were no differences in procedural success between patients with and without AF. The authors conclude that AF was associated with increased mortality at 1 year and higher rates of stroke and major bleeding at 30 days and 1 year after TAVI. Their key findings are 1. Atrial fibrillation is a common arrhythmia in patients undergoing TAVI. 2. AFib is associated with increased mortality, stroke, and major bleeding. 3. Sufficient anticoagulation before TAVI decreases the stroke risk. The next paper is titled Local Epicardial Robotic Enhanced Hybrid Ablation Efficacy Predictors for Persistent Atrial Fibrillation by Dr. Eduardo Celentano and colleagues. The background to this study is that hybrid ablation can manage persistent atrial fibrillation and long-standing persistent atrial fibrillation. Robotic enhanced hybrid ablation offers greater precision and stability. However, the biophysical predictors of effective local epicardial radiofrequency ablation during epicardial ablation are unknown. The objective of these authors' study was to compare the time course of biophysical predictors of epicardial radiofrequency ablation versus no epicardial radiofrequency ablation during the first stage of robotic enhanced hybrid ablation in patients with persistent and long-standing persistent atrial fibrillation. The authors conducted a dual-center retrospective cohort study involving 92 consecutive patients with persistent or long-standing persistent AF, who underwent robotic-enhanced hybrid ablation between January 2021 and May of 2024. The procedures were performed using the Da Vinci system and a unilateral left-sided thoracoscopic approach with patients under general anesthesia through double-lumen endotracheal intubation for selective right lung ventilation. A complete epicardial lesion set included 1. Bilateral semicircumferential pulmonary vein ablation. 2. Complete box lesion set to connect the lesions amongst all pulmonary veins. 3. Ablation of the left atrial posterior wall, excluding the area under the pericardial reflection. 4. Transection of the ligament of Marshall. 5. Ablation of the left atrial ridge from the left atrial appendage to the left superior pulmonary vein. And 6. Exclusion of the left atrial appendage using an epicardial clip. During epicardial robotic-enhanced hybrid ablation, lesions are created using a vacuum-assisted unipolar RF device, EpiSense by AtriCure, set at 30 watts for 90 seconds. Impedance drops are monitored as indicators of local tissue destruction. Epicardial radiofrequency ablation is defined as the completion of a single RF ablation characterized by the disappearance of the atrial electrogram after RF energy application, which is defined as a post-ablation EGM with a bipolar voltage of less than 0.05. When there were persistent atrial electrograms, additional applications were administered. The authors were able to extract the biophysical data, obtaining 1,800 consecutive impedance samples for each RF application within a 90-second period. Further, for each RF application, baseline impedance drops, RF delivery time were collected. The primary outcome was epicardial electrogram disappearance, defined as a reduction of bipolar voltages to less than 0.05 millivolts. Baseline impedance and impedance drop were compared between epicardial radiofrequency ablation and cases without epicardial RF ablation. Univariate and multivariate logistic regression models were used to identify predictive variables. The authors' results show that among 2,474 RF applications with 752 effective lesions, representing 30.4% of the group, the mean baseline impedance was 112 and was higher in the ineffective RF applications versus the effective ones, 122 versus 91 ohms. Also, impedance drops during the first 8 seconds were significantly lower in the effective RF application group. The impedance drops in the effective lesions showed a smooth and continuous decrease over time. Parameters that were associated with effective ablation lesions were baseline impedance and impedance drop measurements during the initial seconds of energy applications. Multivariable analysis also confirmed that baseline impedance and impedance drops at 1 and 8 seconds were the most robust predictors of an effective ablation. The authors were able to use their results to develop a predictive score with an ROC of 0.775. The score values ranged between 0 and 4, and the best cutoff by the Youden test was 3, with 94% sensitivity, 53% specificity, and 65% accuracy. The authors conclude that baseline impedance and progressive impedance drop were strong predictors of local epicardial robotic-enhanced hybrid ablation efficacy. The composite model was a reliable tool for early identification of epicardial radiofrequency ablation, potentially reducing RF delivery and enhancing procedural efficiency. Authors further note that larger prospective studies are needed to validate these findings. The author's key findings are, first, that EpiSense's probe sensing electrodes can be used to assess baseline impedance and impedance drops during robotic-enhanced hybrid ablation for persistent and long-standing persistent atrial fibrillation. Second, focusing on complete signal dropout after RF application and ablation parameters, baseline impedance and progressive and stable impedance drop scores at 1 to 8 seconds were the primary predictors of effective local epicardial radiofrequency ablation. And finally, early impedance parameters can accurately predict acute epicardial RF ablation, potentially reducing RF delivery and enhancing procedural efficacy. The title of the next paper is Effectiveness of Cryoballoon Ablation for Atrial Fibrillation in Patients with Left Common Pulmonary Vein Variant by Dr. Adi Elias and colleagues who represent the Israeli Working Group on Pacing and Electrophysiology. The objective of this study was to examine the outcomes of cryoballoon ablation in patients with the left common pulmonary vein variant. The study uses data from the Israeli Catheter Ablation Registry, which is a prospective multi-center cohort of patients who underwent PVI during the years 2019 to 2021 to identify success rates of ablation. Baseline data collection included age, sex, type of AF, concomitant and prior antiarrhythmic drugs, comorbidities, the CHADS-2 VAS score, LVEF, and left atrial size. Also, procedural data included the ablation strategy, procedure time, fluoroscopy time, pulmonary vein anatomy, and acute complications. The primary study endpoints were acute isolation success of the pulmonary veins, AF recurrence, and the need for repeat ablation procedure at 12 months. The study included 74 patients with the left common pulmonary vein variant and 822 patients with standard pulmonary vein anatomy. Overall, the clinical characteristics were similar between the two groups, except that the CHADS VAS score was 3 in the group with the left common pulmonary vein anatomy and 2 in the standard anatomy group. Low rates of prior AF ablation were observed, 5.5% in the left common pulmonary vein group and 3.6% in the standard anatomy group. The acute isolation success rate of the left pulmonary veins was found to be significantly lower in the left common pulmonary vein variant patients compared with those with a standard anatomy. However, there was no significant difference in the acute isolation success rate of the right pulmonary veins between the two groups. The total number of cryoballoon applications to the left pulmonary veins was significantly lower in the left common pulmonary vein group than in the standard pulmonary vein anatomy group. Also, freeze time delivered to the left pulmonary veins was significantly lower in the left common pulmonary vein anatomy group, but more energy was delivered to the ostium of that group compared with the standard left pulmonary vein anatomy ostium. The difference was 300 seconds versus 210 seconds. In terms of adverse events were infrequent and did not vary significantly between the two patient groups. Notably, pericardial effusions were rare with an incidence of 0.1% overall. Acute reversible phrenic vein injury was similar between the two groups. At 12 months, the rates of AF recurrence did not differ significantly between the left common pulmonary vein anatomy variant group, 17.6%, and the standard anatomy group, 11.1%. Following multivariable adjustment, left common pulmonary vein anatomy was not associated with a higher risk of AF recurrence. Also, the rate of repeat ablation for recurrent AF was not different between the two groups. The authors conclude that they found that isolating the left common pulmonary vein using cryoballoon PVI was more challenging than isolating standard anatomy. But despite this, the effectiveness of cryoballoon ablation in patients with the left common pulmonary vein anatomy did not differ significantly from that in the standard pulmonary vein anatomy group. The next paper is titled Sodium Glucose Cotransporter 2 Inhibitor Use in Type 2 Diabetes Mellitus is associated with a lower rate of atrial arrhythmias in a hospitalized real-world population by Catherine D. Teever and colleagues. I'm going to pretty much just summarize the abstract in terms of this study. The abstract's pretty clear with the objectives, the methods, and the results. As a background, the authors note that SGLT2 inhibitors have been associated with lower rates of cardiac arrhythmias in post-hoc analyses. The real-world effect on cardiac arrhythmias, however, is incompletely defined. The purpose of their study was to determine the effects of SGLT2 inhibitors on cardiac arrhythmias in a real-world hospitalized population. This is a retrospective cohort study performed in South Australia, with 882 patients with type 2 diabetes on oral diabetic therapy, including 33.6 females and a median age of 62.3 years who received SGLT2 inhibitors for their diabetes. They were identified through public hospital admissions between 2011 and 2019. Patients were matched with 3,282 contemporaneous controls who also had type 2 diabetes who did not receive SGLT2 inhibitors. They looked at baseline characteristics were adjusted using inverse probability treatment weighting. The primary outcome was incidence of atrial arrhythmias, and a secondary outcome included incidence of ventricular arrhythmias and cardiac arrest at 2 years. The author's results are first that all-cause mortality was higher in the SGLT2 inhibitor group with a hazard ratio of 2.02, p-value of 0.001, despite propensity matching, which the authors state highlights the greater unmeasured comorbid burden of the SGLT2 inhibitor-treated group. Second, despite this, SGLT2 inhibitor treatment was associated with fewer atrial arrhythmias with a hazard ratio of 0.17, p-value of equal to or less than 0.001 at 2 years. The relationship between SGLT2 inhibitor use and ventricular arrhythmias and cardiac arrest did not reach statistical significance. The authors conclude that in this real-world comorbid inpatient cohort study, SGLT2 inhibitor treatment was associated with a lower incidence of atrial arrhythmias. They also conclude that prospective randomized trials evaluating SGLT2 inhibitors as specific atrial fibrillation pharmacotherapy are underway. The next paper is by Dr. Halim Marzak and colleagues from Strasbourg, France. The title of the paper is Left Atrial Remodeling and Voltage-Guided Ablation Outcome in Persistent Atrial Fibrillation Patients Over 75 Years of Age. As a way of background, the authors note that the prevalence of AF increases with age. The improvement in ablation techniques has widened the indications, particularly in elderly patients. Data on left atrial remodeling and low voltage zone extent in this subgroup are scarce. The purpose of this study, therefore, was to assess the left atrial bipolar voltage, low voltage zone extent, and efficacy of voltage-guided ablation in a cohort of patients with persistent atrial fibrillation according to age. 353 patients from the author's hospital system with persistent AF undergoing a first voltage-guided ablation procedure were enrolled and divided into two groups by an age cutoff of less than 75 years or equal to or greater than 75 years. Left atrial voltage maps were obtained in sinus rhythm. Low voltage zones were defined as less than 0.5 millivolts. The authors performed a propensity score matching analysis to assess the impact of age on left atrial remodeling. The authors found that the left atrial bipolar voltage was lower in elderly patients. Low voltage zones were found in 67% of elderly patients and 30% of younger patients, especially in mild and moderate low voltage zones. However, after propensity score matching, these differences were no longer noticeable. Pulmonary vein isolation alone was performed in 33% of elderly patients and 70% of the patients who were less than 75 years of age, with a p-value of 0.01. Female sex, age equal to or greater than 75 years, estimated GFR, and left atrial volume index were predictive of low voltage zone presence. After 36 months of follow-up, the AF-free survival rate after a single procedure was similar between the two groups. The authors concluded that patients equal to or over than the age of 75 years of age with persistent atrial fibrillation display increased left atrial substrate remodeling compared to younger patients. Left atrial scar did not seem to negatively affect the results of substrate-guided ablation, and the complication rates were low. The author's key findings are, first, in persistent atrial fibrillation, elderly patients display more left atrial electrophysiologic remodeling with lower bipolar voltage, more low voltage zones, and higher left atrial volume. After matching the cohort according to cardiovascular risk factors, these differences are not so clear, testifying to the complex interplay of all cardiovascular risk factors in addition to age in the occurrence of left atrial remodeling. Despite this significant fibrotic remodeling, they have a similar and favorable 36-month outcome after a single voltage-guided ablation procedure with low complication rates. Finally, the authors go on to state that in their analysis, female sex, older age, renal function, and left atrial index volume were predictors of the low voltage zones in patients with persistent atrial fibrillation. However, no predictive factors for atrial arrhythmia recurrence could be identified in the entire cohort. The next paper's title is Adjunctive Posterior Wall Isolation for Patients with Persistent Atrial Fibrillation, a Systematic Review and Meta-Analysis. The first author is Dr. Andre Rivera from institutions in Brazil and several in the United States. The background of this study is the question regarding the benefits of adjunctive posterior wall isolation in persistent AF. The purpose was to perform a systematic review and meta-analysis of PVI with or without adjunctive posterior wall isolation. PubMed, Embase, Cochrane, and clinicaltrials.gov databases were searched for randomized controlled trials that compared PVI with or without posterior wall isolation in patients with persistent AF. A random effects model was used for the meta-analysis. Atrial tachyarrhythmias were a composite of AF, atrial flutter, or atrial tachycardia. The meta-analysis included 8 randomized clinical trials with 1,104 patients, 546 who had PVI alone and 558 who had PVI plus posterior wall isolation. Compared with PVI alone, adjunctive posterior wall isolation significantly increased freedom from ATAC recurrence with a relative risk of 1.13, p-value of 0.036. A sub-analysis of patients with longstanding persistent AF showed a greater effect of posterior wall isolation. A subgroup analysis of posterior wall isolation techniques indicated no significant difference for atrial tachyarrhythmia recurrence with box isolation alone, whereas a pooled analysis using only studies with direct posterior wall ablation favored the adjunctive posterior wall isolation group with a relative risk of 1.39, p-value of 0.01. Adverse events did not significantly differ between the two groups. The authors conclude that their findings support that adjunctive posterior wall isolation to PVI is an effective strategy compared with PVI alone for reducing atrial tachyarrhythmia recurrence in patients with persistent AF without compromising safety. Notably, patients with longstanding persistent AF, according to the authors, may benefit more from posterior wall isolation. So their key findings are: first, adjunctive posterior wall isolation increased freedom from atrial tachyarrhythmias compared with pulmonary vein isolation alone in patients with persistent AF. Second, there were no significant differences between the groups with regard to atrial esophageal fistula, pericarditis, cardiac tamponade, or phrenic nerve injury. There was a higher freedom from atrial tachyarrhythmias associated with posterior wall isolation amongst patients with longstanding persistent AF compared with PVI alone. The title of the next paper is Non-Invasive Electrocardiographic Imaging Assessment of Conduction System Pacing, a Novel Algorithm to Assess Intraventricular Synchrony, by Dr. Ivan Eltsov and colleagues from Brussels, Belgium. In this study, the authors assessed ventricular activation and synchrony in patients with a left bundle branch area pacing device using electrocardiographic imaging, or ECGI. The study focused on 25 consecutive patients who underwent a left bundle branch area pacing device implant. Electrocardiographic and ECGI analyses were performed the day after implantation. Patients were placed into two groups based upon their pre-procedural ECG as being narrow or wide. The post-procedural data from the 12-lead ECG and ECGI included native and paced QRS, left ventricular activation time, right ventricular activation time, and V1 to V6 activation delay. Total ventricular activation times from the RV and the LV, both intrinsic and paced, were collected off the ECGI, and intraventricular desynchrony were calculated based on the ECGI. The patients were followed for 12 months. Post-left bundle branch area implant showed the permanent pacemaker placement was appropriate on all patients. Both biotronic and Medtronic leads were used. At the end of the procedure, and based upon the ECG assessment, all patients were divided into two groups: paced QRS less than 130 milliseconds or equal to or greater than 130 milliseconds. The authors then analyzed their ECGI data and were able to construct an algorithm that was helpful to confirm appropriate left bundle branch area pacing to maintain desynchrony. So I'm going to walk through this algorithm and point you to the great figure that is in their paper. So it starts with looking at the paced QRS. If that measurement is less than 130 milliseconds, the next step is to see what the measured V1 activation delay is. If this was positive or near zero, then this was a good result with a total ventricular activation time of less than 130 milliseconds, consistent with good synchrony. On the other hand, if the V1 activation delay was not positive or zero, this correlated with desynchrony and a total ventricular activation time that was greater than 130 milliseconds. Next, looking at the group with a paced QRS equal to or greater than 130 milliseconds, if the V1AD was positive or zero, then the delayed RV activation time was noted, and if this was equal to or greater than 120 milliseconds, this finding was associated with an acceptable total ventricular activation time around 130 milliseconds. However, if the V1AD was not positive or near zero, then the total ventricular activation time was greater than 130 milliseconds and consistent with desynchrony. The author's key findings include: 1. Electrocardiographic imaging can bring significant value in the assessment of intraventricular synchrony after implantation of a left bundle branch area pacing device. Second, a specific measurement technique has been developed to properly assess the intraventricular synchrony using ECG imaging. Third, this method can be used to compare the synchrony between intrinsic and paced rhythm. And fourth, additional 12 electrocardiographic parameters predicting ECGI measurements and therefore intraventricular synchrony were identified. The title of the next study is Prognostic Value of the Modified Model for End-Stage Liver Disease Score in Patients Treated with Cardiac Resynchronization Therapy by Dr. Tianling Wang and colleagues from multiple hospital centers in China. This study looks at CRT in patients with hepatorenal dysfunction. The authors investigate the prognostic value of the modified model for end-stage liver disease, which has two versions. One, the International Normalized Ratio, or the MELD-XI score, and one with albumin replacing the International Normalized Ratio, or MELD-albumin score. This is a retrospective analysis of 365 patients with mean age 59 years, of whom 65% are male, undergoing CRT implantation between 2007 and 2019. Patients were divided into 4 groups based upon the modified MELD score quartiles before having their CRT implant. The primary endpoint was a combination of all-cause mortality and heart failure hospitalization with a secondary endpoint of CRT response at 6 months. The results showed that during a mean follow-up of 3.3 years, 168 patients reached the primary endpoint. Logistic regression revealed that the MELD albumin score was independently associated with CRT response, even after adjusting for covariates, with an odds ratio of 1.10, p-value of 0.013. Kaplan-Meier analysis revealed that patients with a higher MELD-XI score and MELD-albumin score had a greater risk of adverse outcomes. Next, Cox proportional hazards analysis showed that the modified MELD score remained significantly associated with adverse outcomes after adjusting for clinical and echocardiographic factors. Furthermore, the RLC analysis indicated that the MELD albumin score provided a stronger prognostic value for long-term adverse outcomes in patients undergoing CRT than the MELD-XI score. The authors conclude that the MELD albumin score may be useful for stratifying patients at risk for CRT response and adverse outcomes in those undergoing CRT for heart failure. The title of the next paper is Intracardiac Electrogram Analysis May Allow for Prediction of Lesion Transmurality After Pulsed Field Ablation of Atria in a Porcine Model by investigator Jeanne E Poole and colleagues. The authors note as background to this study that PFA is increasingly used for AF ablation, but the intraprocedural guidance for PFA to ensure durable pulmonary vein isolation is lacking. The purpose of the study was to quantify changes in intracardiac electrograms following PFA and radiofrequency ablation and assess whether these changes are predictive of transmurality using a swine model. 38 atrial lesions using PFA or RFA were created in 5 swine, and they monitored IEGMs continuously for up to 30 minutes post-ablation. Discrete wavelet transformation was used to quantify the most characteristic IEGMs. The effects were evaluated in separate frequency bandwidths. Regarding the results, after the ablation, the investigators observed a reduction of the bipolar IEGM amplitude for both PFA and RFA and an increase in unipolar IEGM amplitude predominantly for PFA. These changes were due to 2 mechanisms with different frequency content. The low frequency content of unipolar IEGMs, 1 to 16 Hz, according to the authors, allowed them to then discriminate between transmural and non-transmural lesions in the case of PFA. The rate of reduction of initially increased current of injury effect reflected in the low frequency content of unipolar IEGMs within the first few minutes post-ablation was significantly higher and more pronounced for non-transmural lesions. The authors conclude that this study shows that unipolar IEGMs can be used to differentiate between transmural and non-transmural atrial lesions within minutes after PFA in a porcine model, with implications for development of intraprocedural guidance of PFA procedures. The next paper is published in our Global Voices section. The title is Gender Disparity in Quality of Life in Patients with Atrial Fibrillation During the Syrian Conflict, an observational cohort study by Dr. Ibrahim Antoun and colleagues. I want to just read a little bit of the background because I think it's important to put the study in perspective. The authors note that Syria has been in conflict since 2011 and deprived of healthcare funding and resources, which was particularly exacerbated during the coronavirus pandemic in 2019 and a cholera outbreak. Less than half of its hospitals currently operate at total capacity, and about 50% of the healthcare workforce has been forced to leave because of conflict. More than half of the Syrian population suffer from poverty, which is suggested to increase AF risk. A recent effort has been made to explore AF management outcomes in Syria. However, the quality of life of patients with AF in Syria is a critical concern given the country's damaged healthcare system. The authors note that in conflict zones, disparities are likely amplified by disrupted access to care, increasing caregiving burdens and societal expectations, leaving females particularly vulnerable to diminished health outcomes and well-being. Recognizing this gender impact is fundamental for creating targeted interventions that effectively address the distinct needs of male and female patients in conflict-affected areas. This study assesses the gender disparity in quality of life in patients with atrial fibrillation admitted to a tertiary center in Latakia, Syria. As further background, the authors note that the EuroQOL-5 questionnaire is the first validated questionnaire to evaluate AF in Syria in the Arabic language. The objective of this study is to evaluate the gender disparity of quality of life in Syrian patients with atrial fibrillation during the ongoing conflict. The authors evaluated patients admitted to the emergency department of the Tishreen University Hospital in Latakia, Syria, with AF as the primary diagnosis between June 23 and June 2024. The study included 406 patients, of whom 180 or 44% were male, and the median age was 67 years. Components of the questionnaire compared the answers between males and females. Compared with males, women had more congestive cardiac failure, 32% versus 22%, and were more likely to be uneducated, 48% versus 27%. Females demonstrated poor quality of life across all scoring dimensions, including activities, mobility, self-care, pain, and anxiety. The EuroQOL visual analog scale was lower in women versus men, 49.8 versus 79.8. A multivariable logistic regression demonstrated that women and congestive cardiac failure were independently associated with poor quality of life. The authors conclude that Syrian women admitted with AF had poorer quality of life than did their male counterparts. Heart failure and female sex were independent predictors of poor quality of life. And finally, that this study contributes to understanding gender disparities in quality of life amongst patients with AF in Syria. It highlights the need for comprehensive healthcare strategies that address the unique challenges faced by female patients. The next paper is a topics in review. The title is Narrative Review of Adalimumab for the Treatment of Cardiac Sarcoidosis. The authors note that cardiac sarcoidosis remains the second leading cause of death in patients with sarcoidosis because of the association of heart failure and arrhythmias. Corticosteroids have been the first-line therapy, but because of significant side effects, other medications have emerged, including infliximab, a tumor necrosis factor inhibitor, and a newer alternative drug, adalimumab, that has recently emerged. The authors go on to review the literature for the use of adalimumab in cardiac sarcoidosis. The next paper is a case report. The title is Exploring Posterior Superior Bundle Area Pacing in Novel Atrial Pacing Modality with Efficient Anatomical Access, Stable Pacing Lead Fixation, and Reserved Interatrial Synchrony by Dr. Jeanne E and colleagues. This case report describes two cases of dual-chamber pacing in which Brockman bundle was initially targeted, but both ultimately resulted in successful pacing in the posterior superior bundle area within the superior vena cava, as verified by follow-up computed tomography imaging. The key findings are first that sensing amplitude in the posterior superior bundle area showed a good electrical engagement, while a split electrogram indicated a possible potential at the PSB. However, the anatomical location is the key point of the pacing lead tip position, utilizing efficient anatomical access in this PSB area. Second, follow-up results at 11 and 9 months after PSB bundle area implantation showed a stable electrical parameters with no perforation observed, and post-Doppler measurements in one case showed reserved interatrial synchrony. Finally, further clinical research is necessary to investigate the electrical and anatomical characteristics of the posterior superior bundle area, its electrical and anatomy-involved capture criteria, and long-term reliability and clinical outcomes. The next paper is a research letter. The title is Expedited and Safe Discharge Path for Extraction Patients Utilizing a Temporary Permanent Pacemaker by Drs. Angela Krebsbach and colleagues from Oregon Health Sciences University. This research letter addresses the need for temporary pacemaker after lead extraction due to infection in patients requiring long-term antibiotics. In this setting, so-called temp-perm pacemakers using an active fixation lead with externalized generators have gained a lot of use and interest. The authors reviewed data from patients who underwent CIED extraction between July 2012 and October 21 at Oregon Health Sciences University. A temporary permanent pacemaker was placed via the right internal jugular vein in 12 patients who were discharged from the hospital to home. The total duration that patients had their pacemaker ranged from 6 to 153 days with a mean of 36 days. Patients had weekly device interrogations and dressing changes in the device clinic. Stable device parameters were noted with each visit, and no complications were reported by patients or providers during these follow-up visits. After completion of antibiotic therapy and confirmation of infection clearance, all patients underwent successful outpatient reimplantation of a new permanent CIED. The author's key findings include: 1, temporary permanent pacing can be a standard bridge for post-extraction after cardiac implantable electronic device infection. 2, it is safe to discharge patients to home with a temporary permanent pacemaker while awaiting reimplantation of a permanent device. 3, close outpatient monitoring after discharge with a temporary permanent pacemaker is critical to ensure patient safety. The next paper is also a research letter. The title is Incidence of Systemic Thromboembolism After Transvenous Lead Implantation in Patients with Simple Intracardiac Shunts by Dr. Mitsutaka Nakashima and colleagues. This research letter addresses the question of the thrombotic risk of transvenous right ventricular leads in the setting of patients with intracardiac shunt. This single-center study evaluates patients with what they define as simple cardiac shunts, which are defined as one of the following 5 types. 1, atrial septal defect, isolated, unrepaired, or residual after closure. 2, ventricular septal defect, isolated, unrepaired, or residual after closure. 3, primary ASD with partial AV septal defect, unrepaired, or residual. 4, residual ASD or VSD after complete AVSD repair. And finally, residual VSD after tetralogy of Fallot repair. The study included patients who underwent transvenous implantation of CIEDs between 1976 and 2021. The endpoint was the systemic thromboembolic event rate after CIED implantation. The follow-up period was defined as the time until occurrence of systemic thromboembolism, complete lead extraction, or death. The key findings were that 1, in adults with congenital heart disease and simple intracardiac shunts, the risk of thromboembolism associated with transvenous lead implantation was not significantly increased compared to ACHD patients with closed simple intracardiac shunts. 2, in patients with simple intracardiac shunts, no thromboembolic events were observed even in the absence of anticoagulant therapy. 3, in both patients with and without intracardiac shunts, asymptomatic thromboembolism was not detected on CT or MRI following transvenous lead implantation. Well, that brings us to the end of all of the papers that are in the March issue. Thank you, as always, for listening. We'll be happy to be back in a month with the next podcast. I also want to remind all of our listeners that if you are engaged in digital health, digital technology, or research using AI or deep neural networks, anything in that space, we are really trying to expand that section of our journal, and we would appreciate it if you consider us for your publication. Otherwise, have a great rest of your day or evening wherever you are, and we'll talk to you next month.